Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, Stitcher Radio, and on your favorite podcast app. This episode is hot. Convergence 2022 is here. And with that, new trials, new medications, and new results. I've invited my partner in crime, Dr. Vicki Shanmugam, host of our sister podcast, ACR Journals On Air, to discuss 3 pivotal trials that will be presented at Convergence 2022. Until this minute, the results of these studies were under embargo, but Vicki and I will dissect them for you and put them on a platter. Well, sort of. Metaphorically speaking, you know what I mean. Enjoy. Vicki, welcome again to our show.
Thanks for having me, John. It's a pleasure to be here with you for this joint hot off the press edition.
So this is really exciting, and it's the first time we're doing this. Can you tell us a little bit about how this episode is going to flow?
I'm going to start with a couple quick disclosures before we get started. Firstly, all of the links to the manuscripts we're going to be discussing today can be found in our show notes from today. And secondly, since a number of these studies are sponsored by pharmaceutical companies, the various disclosures for the authors are also in the show notes, and those can be found on your website, acronair.org. I will also note that the selection of these 3 manuscripts for inclusion in the podcast this year was done by the editors at Arthritis and Rheumatism, which is published by Wiley, who also provide support for the production of this podcast.
All right. So what do we have in store? What's our first article that we'll be talking about?
Okay, I'm going to get right to it. And we're going to start with a really exciting manuscript in lupus, because everybody loves a lupus trial, right?
Those are tough ones.
So this manuscript is entitled Deucravacitinib, a tyrosine kinase inhibitor in systemic lupus erythematosus, a phase 2 randomized double-blind placebo-controlled trial. Now, it should be noted that there are a whole host of deucravacitinib studies being presented at Convergence meeting. It is being studied as a treatment both for psoriatic arthritis and lupus. And the data in this particular manuscript is being presented in abstract number 1117 at Plenary 2, which is on Sunday morning at 11:30. And I think the presentation time for this specific manuscript is at 12:45. The lead author on the manuscript is Dr. Eric Morand. And it's always exciting to have results of a randomized controlled trial in lupus presented at the meeting, because lupus studies have historically been so challenging.
Right.
This particular study is investigating an oral selective inhibitor of tyrosine kinase 2, or TYK2. And as you know, TYK2 is an intracellular kinase that mediates signaling of type 1 interferon and other cytokines, including IL-10, IL-12, and IL-23. So as you might expect for a drug blocking this pathway, deucravacitinib has been studied and actually now approved by the US FDA for the treatment of adults with moderate to severe plaque psoriasis. So I'm going to take a little aside here and give you a bit of color. This particular phase 2 study in lupus and the various other kind of studies that have been investigating this agent in lupus are being referred to as the Paisley study, or Paisley studies. And you know, that's cute because Paisley actually has SLE in the name. And I hadn't realized that until I started hearing about this study. Now, I grew up in Britain, where there was a period of time in the 60s, 70s, and 80s when Paisley was a very fashionable fabric. And I don't know whether you know this, but one of Britain's more famous exports, John Lennon, actually loved Paisley so much that he had his Rolls Royce painted Paisley.
Wow.
It moved with him, actually, when he moved from the UK to the US. And then some years later got donated to the Smithsonian to clear some kind of tax snafu he was having. So with that image in our mind, I thought we could take a deep dive into the Paisley study.
That's great. What a story. I actually had to look up while you were speaking what paisley was. I thought it was a color, but I guess it's a pattern. I think my daughters would definitely know that when I speak with my daughters about, this purple ball that we have, they actually correct me all the time and say, it's not purple, Dad, it's magenta. But yeah, I love the idea of that paisley Rolls Royce. And now I think that image will be forever linked to this study, thanks to you, Vicki.
I feel like it gives SLE a whole new flavor. So let's get back to the study. So this is a 48-week phase 2 study designed to evaluate efficacy and safety of deucravacitinib. They studied 3 different doses of the drug against placebo. So a 1-to-1-to-1-to-1 ratio comparing 3 milligrams twice a day, 6 milligrams twice a day, and 12 milligrams once a day against placebo. And they enrolled patients, obviously, with confirmed active lupus. So that is to say, patients who met the SLIC criteria for lupus, who were positive for at least one antibody of either ANA, double-stranded DNA, or Smith, who had a SLEDAI-2K score of greater than or equal to 6, and either a BILAG 2004 Index A activity indicating very active disease, or at least 2 BILAG B indicators of moderate disease manifestations in the musculoskeletal or mucocutaneous domains. All patients had to be on a background antimalarial or other immunosuppressant, and they were permitted to also be on 30 milligrams or up to 30 milligrams of oral prednisone or equivalent per day at enrollment. Now, there were some notable exclusions, and I think this is important to mention. In particular, they excluded patients with active severe lupus nephritis, although I will note that there is now a sub-study, the Paisley LN study, that is ongoing to investigate the lupus nephritis population. They excluded from this phase 2 study also patients with active neuropsychiatric lupus, and I think that's notable and important to remember. And then additionally, they had some exclusions related to recent history of herpes zoster or simplex and patients with recent influenza. So those patients with those fairly recent viral infections were excluded for 12 weeks prior to randomization. So this study was obviously blinded and randomized, and they stratified the randomization for steroid dose, SLEDAI score, and geographic region of recruitment. And I think that was stratify a little bit for race and ethnicity. They did also notably require that patients who were on more than 7.5 milligrams of prednisone equivalent were weaned down to 7.5 milligrams a day or less between weeks 8 and 20. They then had to remain stable between weeks 20 and 32. And then a further optional steroid taper was permitted from week 32 to week 40, with a stable dose again required between weeks 40 and 48. And if you're wondering why that was, well, those periods of stability were to coincide with their endpoint measures. So week 32 was the point at which they were measuring their primary endpoint. And week 48 was when they evaluated their secondary endpoints.
Got it. That makes sense. So they didn't want people to have very high doses of prednisone right before they were going to be evaluated for those primary endpoints. So what exactly were those endpoints?
Well, the primary endpoint, which they evaluated at week 32, was the number of patients meeting the SLE Responder Index, or SRI-4. And as a refresher, to meet an SRI-4, patients had to meet all of the following. So a 4-point reduction in the SLEDAI-2K, no new disease activity in the BILAG A, and no more than one additional BILAG B, and then no worsening of the physician's global assessment of disease activity. The secondary endpoints, as I said, were evaluated at week 48. And I'm going to summarize these. They're obviously included in detail in the manuscript. But the secondary endpoints were the proportion of patients achieving the SRI-4, the proportion of patients achieving a BICLA, which is a BILAG-based composite lupus assessment response, and then the proportion of patients achieving the LLDAS, or the lupus low disease activity state. And we'll actually come back a little bit and talk about that when we go through the results. They also had as a secondary endpoint the CLASI 50, or the cutaneous lupus erythematosus disease area and severity index 50, so 50% reduction in that score, and the change from baseline in the tender swollen joint count based on a 40-point score. That actually became one of their exploratory endpoints. They were looking for this concept of a joint count 50, so a little bit like our previous RA studies where we had the ACR 50 response, and they were trying to measure that for these lupus patients. They also were exploring the time to the SRI-4 as an exploratory endpoint. They looked at changes in mean complement levels and the double-stranded DNA titers. And finally, an exploratory biomarker looking at change from baseline in the whole blood type 1 interferon gene signatures. In addition to those, they had the standard safety parameters, so adverse events, vitals, EKG, clinical labs, physical exam findings, as you would expect from a phase 2 study. What I will say as you read through this manuscript, I won't go deeply into this, but if you want to get some statistical envy, then I recommend you read the statistical analysis plan in this manuscript. It's a thing of beauty, well thought out, really robust analysis. And I think one of the challenges lupus has historically been facing in its clinical trials is how to account for the heterogeneity of disease. This study team seemed to have really understood that and developed an analysis plan to really address some of that heterogeneity and those challenges. So that's a lot of build-up. You want to hear about the patients?
Yes. First, I don't think I would ever have statistical envy. It's certainly not one of my strength suits. But yes, so tell me about the patients. Who were these patients enrolled?
So they screened 772 patients between September 21st, 2017 and October 28th, 2021. So this was squarely a pandemic study. Actually, a really impressive achievement if you think about the disruption around the world during that time. Of those 772 patients, they randomized 363. So it was roughly 90 into each arm. And about 3/4 of those patients completed the full 48 weeks of treatment. The main reasons they had for patients withdrawing were relocation and personal problems. I think that was truly a reflection of doing this study during a pandemic. And the most common adverse events leading to withdrawal were GI complaints and then cutaneous side effects, pretty balanced across the treatment groups. Their population was 65% white, 9% Black, 12% Asian, with the distribution consistent across each treatment arm. So their stratification worked quite well. 80% of their patients were on glucocorticoids at baseline, and 32% were on combination therapy with antimalarials and other immunosuppressants and glucocorticoids. So that breakdown also balanced across the groups.
Great. So how did these participants do? Did they actually hit their primary endpoints?
The results are quite exciting. So 58.2% of patients achieved the SRI-4 in the 3 milligram BID arm, giving an adjusted odds ratio of 2.8, and 49.5% in the 6 milligram BID arm with a ratio of 1.9. So those were both statistically significant compared to the 34.4% response rate in the placebo arm. Interestingly, the higher dose once daily, the 12 milligram once daily dose, still did have a higher response rate than placebo at 44.9%, but that did not reach statistical significance. Additionally, and this is interesting too, the median time to achieving that SRI-4 response was 85 days in the 3 milligram BID arm, 92 days in the 6 milligram twice daily arm, and 111 days in the 12 milligram once daily arm.
Wow, it's always interesting. Usually we see dose response where higher doses, you have more of the effect desired, maybe more adverse effects as well. And I guess this was not the case for this study.
Yeah, super interesting, right? So perhaps suggesting that less is more when it comes to interferon inhibition, and probably reflecting some of the pharmacodynamics of the drug, of the molecule. Supporting that further, actually, are their secondary endpoints. So when they look at the week 48 data, they definitely showed and kind of carried those results through that they more frequently achieved those secondary endpoints in the 3 milligram twice daily dose compared to placebo. And the 6 milligram twice daily dose and the 12 milligram once daily dose didn't reach statistical significance. So the 3 milligram twice daily dose had significant improvement compared to the placebo arm in the SRI-4, 57.1% compared to 34.4%, and the BICLA, 47.3% compared to 25.6%. So both reaching statistical significance in that 3 milligram twice daily group. Now, I'm going to talk for a little bit about the LLDAS, which, as you know, is a much more stringent treat-to-target measure of response in lupus studies. It, again, showed statistically significant higher attainment in that group receiving the 3 milligram twice daily dose compared to placebo. So 36.3% of patients in the 3 milligram arm achieved the LLDAS compared to only 13.3% of the patients in the placebo group. So that's actually really impressive. I know these numbers sometimes are hard to interpret in lupus, but that is an impressive response. And I think really exciting for the lupus community to see that. Organ-specific endpoints for skin using the CLASI 50 and the arthritis using that change in joint count also significantly improved in that 3 milligram group compared to placebo. So good news for lupus.
That's really exciting, Vicki. What about interferon? Did they note any effects of the interferon signature of the baseline interferon signature of patients and their response?
Yeah. So, that exploratory interferon biomarker endpoint that we talked about, so those figures are actually tucked right at the back of the proof that they sent us in case you were having trouble finding them. And the figures speak 1,000 words because not only do the response graphs for the primary endpoints look good, but these exploratory endpoints, including the complement results, the double-stranded DNA responses, and this interferon gene signature, all of these measures were evaluated using percentage change from baseline, and the graphs are beautiful. The double-stranded goes down, the complement comes up. All of the treatment groups showed this rapid, within 4 weeks, dampening down of the interferon gene signature.
Great. So it sounds like the drug is effective, but what about its safety?
So the rates of adverse events were actually reassuringly similar in the placebo and the 3 treatment arms. The most common adverse event in the treatment arms was upper respiratory tract infections, nasopharyngitis, headache, and UTIs. They had 1 patient with a breast cancer in the 3 milligram arm, 1 patient with a vaginal squamous cell cancer in the 12 milligram arm, and 1 non-melanoma skin cancer in the placebo group. Nobody died. There were no opportunistic infections. Nobody got TB, no thrombotic events, and no major cardiovascular events in this study, although obviously it's small numbers. There is a bit of a worry about herpes zoster risk, and they were looking at that very specifically. And the good news is that no one in this study developed disseminated zoster. They did have some patients have localized zoster, although those rates were similar in the treatment arms and placebo. We know that glucocorticoids play a role in that too. Notably, they did see a higher rate of oral herpes simplex in the treatment groups compared to placebo. And it's quite possible that some of those signals may change in magnitude as follow-up studies are done on these agents. So I would say the jury's still out a little bit on that, but no tremendously worrisome signals at this point in time based on this data.
And Vicki, you mentioned at the beginning that they did the study in the middle of the pandemic. So did they have any data about the effects of COVID on patients on this drug?
Yeah, great question. So they did have about 3 to 5% of patients develop COVID. The numbers are too small, really, to draw firm conclusions. They don't give us a huge amount of detail about the outcome of those COVID infections for these patients. So we don't get any information from this manuscript about hospitalization risk, intubation risk, death, or long-term implications. Did these patients develop long COVID and those types of manifestations? They did have, not unsurprisingly, a small number of patients who got COVID, actually probably smaller than I would have expected given the prevalence of COVID around the world during that time. I actually think that may well be that the patients who chose to stay on this study were probably pretty cautious about, how they interacted with the world during that time. So I think their low infection rates are probably related to that, not some protective role of the study drug or other agents in the study. So far, at least, I think for the patients on the study drug, they didn't seem to have any higher risk of COVID than placebo. I will also give a sidebar. They did not tell us anything about vaccination in these patients or whether they were getting any other therapies like monoclonal antibody therapies.
Great. Wonderful study. And it's so great to see more drugs being developed for lupus, which, for many patients, we struggle with getting them into remission as we would like. I think a couple of things about this study that I thought sort of give me pause was the lack of the dosing effect. As we mentioned initially, we expect more to have a greater effect, and this was not the case. So I always think, is this a fluke, right? Or is it, as you mentioned, is there just a sweet spot of where you want the interferon levels to be to get the greatest response? And then the other thing, the proportion of Blacks and minorities in the study does not reflect the prevalence of lupus in minorities. And it always, gets me to think about how we could improve enrollment of minorities in research studies in general, and certainly for lupus studies in specific.
Yeah, and I think that issue is an ongoing challenge, specifically with lupus studies. And we know we've had challenges with that in the past. And I do think the investigator community for sure is really well aware of it. I think they are trying to address those issues. I think they structured the study as best they could. And I don't know that anyone could have predicted the pandemic hitting and all of these challenges that they have faced. But regardless, I think it's an exciting manuscript, and I'm excited to see what the audience and ACR Convergence think of it.
Absolutely. Always great to have more tools in our toolbox to treat complex patients.
Yeah. So, John, tell me about your next manuscript. I think you had an update on the TULIP study.
Right. So if you guys can remember, the TULIP studies were studies about the use of anifrolumab, which is a monoclonal antibody against type 1 interferon receptor. The TULIP-2 study was published in the New England Journal and basically showed that among people with systemic lupus, those that were on anifrolumab had a higher response as measured in BICLA versus placebo, 48% versus 32%. They showed that anifrolumab had a glucocorticoid sparing effect. And in terms of side effects, zoster and bronchitis were the main adverse events. And the results of TULIP-1 and TULIP-2 actually led to the FDA approval of anifrolumab for the treatment of lupus. The study that I'm talking about today is called a randomized placebo-controlled phase 3 extension trial of the long-term safety and tolerability of anifrolumab in active systemic lupus erythematosus, which is being presented as abstract 1652 on Monday, November 14th in the oral abstract session on lupus treatments, which is from 9 to 10:30. And it will also be published in Arthritis and Rheumatism. So what the study authors wanted to do is sort of assess the long-term safety and tolerability of anifrolumab as compared to placebo in patients who completed either the TULIP-1 or TULIP-2 trials. So that means that patients had to meet criteria for TULIP-1, which was basically having moderately to severely active lupus. But like the trial that you mentioned, Vicki, they also excluded patients with active severe nephritis or neuropsychiatric lupus.
And just to clarify, John, so this is like a 3-year extension of the original 1-year studies. So giving us basically 4-year data on some of these patients. Is that right?
Yeah, it's really interesting study. Exactly. So it's like now we have 4 years of data on these patients. And the interesting thing is that it also happened to coincide with the pandemic. So we have a little bit of data about the effects of COVID among people taking anifrolumab. It's a really, really large study, as for lupus. There were about 600 patients that had finished TULIP-1 and TULIP-2, and of those, about 550 actually enrolled in the long-term study. And what they did was, for anybody that was on anifrolumab 300 milligrams at the end of TULIP-1 or TULIP-2, they stayed on the 300. For people that were on the lower dose, 150 milligrams, they were actually increased to the 300 milligram dose. And then the patients on placebo were randomized again, either to continue receiving placebo or anifrolumab 300 milligrams. So in the end, most of the patients were on anifrolumab, and one out of, I think on a 4-to-1 ratio, anifrolumab to placebo.
And during that period of this extension study, so it's a long time, right? Could they change other immunosuppression during that time? Were they abiding by the original study rules, or how did that work during this extension?
So this was sort of like a pragmatic trial. They wanted to see the effects of this drug out in the wild so that, investigators could change background immunosuppression. I think the only things that were excluded were things like biologics, IVIG, or high doses of IV steroids were forbidden. But otherwise, they can be on other drugs. Those drugs could change according to investigators' clinical judgment.
That's interesting. I was wondering then, does that mean that they lose people or people have to withdraw if they developed, for example, lupus nephritis or neuropsychiatric lupus during that follow-up time? Would those patients, obviously then requiring high-dose steroids, would they be lost then to the follow-up?
That's a good question. I'm not entirely sure. I think you're probably right that they would have to drop out if high doses IV steroids would be needed for that group.
I feel like the data that we really need in the community is sort of time to flare, or if we're looking at drugs for remission maintenance, we want to know what's the risk of a future flare, right?
Absolutely. So this study, I have to say, was mainly a safety study. So they really were determined to see if there's any long-term safety signals that wasn't picked up in either the TULIP-1 or the TULIP-2 trial. And I have to give it to them that following these patients, for the 1 year that they were on TULIP and for another 3 years on the extension trial was really difficult and huge. And this trial took place among 119 different sites in 16 different countries. So it was a huge undertaking.
Yeah, always impressive, these massive studies, right?
Really. Most of the, 70% of patients that had been assigned to active drug completed the trial as compared to 48% of patients on placebo, which tells you there's maybe a signal about, efficacy.
Yeah.
The most common reason why patients dropped out on the placebo trial were lack of efficacy.
Yeah. And I feel like that's super important, right? Like that data, we kind of need to know.
That's definitely encouraging. The most common adverse events that they found were nasopharyngitis, some UTIs, some upper respiratory tract infections, which were slightly more common in the anifrolumab treated group as compared to placebo. There was also increased rates of herpes zoster in the active treatment group as compared to placebo, but these rates decreased over time. Overall, deaths throughout the study were rare, though slightly more common in the anifrolumab group. And then, they were looking for rare serious adverse events like opportunistic event and infections, malignancy, anaphylaxis, major cardiovascular events. They were all fairly rare among both groups.
What about COVID?
Yeah, so really interesting. The interferon is sort of our body's way of fighting off viruses. And if you cut down on the interferon, maybe you make the body less able to confront viral infections like SARS-CoV-2. Not surprisingly, they did have higher rates of serious adverse events related to COVID in the anifrolumab group, including 4 deaths. Although I have to say that, these deaths occurred early in the pandemic and actually when the virus appeared to be more virulent. And by the time that people became vaccinated in the study, there were actually no COVID adverse events in patients after vaccination.
Yeah, that's really reassuring.
Yeah, so it seems like certainly it makes you more susceptible to viral illnesses, but if you are vaccinated, then that certainly protects you. Sort of the safety is sort of what we had expected and what we had seen in TULIP-1 and 2. And in terms of efficacy, anifrolumab continued to show improvements in the SLEDAI-2K, which was sustained over time as compared to placebo. It also had a steroid-sparing effect. So, for instance, at year 4, a third of patients on anifrolumab were completely off steroids versus about a fifth of the patients on placebo.
Yeah.
And 3/4 of patients were in doses of 5 milligrams or less of prednisone.
I think the analysis in this one is interesting. I kind of wish they'd done more with that, understanding the placebo arm better, and particularly the understanding of the dropouts on the placebo arm, right? Because I really do sense that the people who dropped out were the people who became active. And then you're left with a placebo arm that had pretty low lupus activity, after this 4-year process. Those patients were probably going to be stable long-term regardless. And so, I feel like I'd like to see them slice and dice that data a little bit better, just to give us a bit more understanding of the natural history. If there are some people who do have relatively stable lupus in remission, and what we really need to know is the people who dropped out from the placebos.
Great point, Vicki. We have to remember that this is a very selected patient population. Most of them tolerated anifrolumab for a year while they were on TULIP. And you could imagine that people that had adverse events to the drug would have dropped out of TULIP 1 or TULIP 2 and would not have been eligible to the extension arm. So it's a selected study. As we discussed with the study that you presented, this was also a largely white cohort with, 68% of participants being white, only 10% Black and 10% Asians. 25% of the overall cohort, reported having a Latino ethnicity. Fortunately, there were no surprise adverse events. Perhaps they found a signal of COVID-related events in people that were unvaccinated, which is certainly a reminder to vaccinate your patients. There was a signal of zoster reactivation. But again, this actually took place at a time when the Shingrix vaccine wasn't available to those under 50. So perhaps, if you vaccinate your patients against COVID, against zoster and any other viral illness, certainly flu, maybe it can mitigate some of that risk.
Yeah, I completely agree. And I'm thankful again to the investigators for doing this study. I think it does show foresight of the companies to do these long-term extension studies and give the community this safety data. And I'm actually really looking forward to having the investigators on our Journals on Air show so that we can discuss that paper further.
Absolutely. I'm so looking forward to listening to see what the authors have to say and to give us a little bit about the background and the nitty-gritty of these really large studies and how they actually took place. Vicki, tell me, you said you had something else in store for us.
Yeah, let's change tack a little bit. I'm going to pick up our last manuscript, which is Genicular Nerve Block for Pain Management in Patients with Knee Osteoarthritis, a randomized placebo-controlled trial. First author on this study is Ernst Shanahan from the Flinders Medical Centre in Adelaide, South Australia. This work is being presented as abstract 1892, which is in poster session D on Monday, November 14th from 1 to 3 p.m. I actually think this study should get a big shout out because it's not pharma sponsored. It's an investigator initiated study that was funded by a small seed grant from the Flinders Foundation. I also want to mention that this university's motto is fearless. I think that the investigators really lived that slogan in doing their study. So essentially what they wanted to do is look at the efficacy of ultrasound-guided genicular nerve block for the management of pain from knee osteoarthritis. They randomized people and then within 2 weeks administered these 3 injections, essentially during that same procedure, of Celestone chondros with bupivacaine. And they compared that to sham injections of placebo. So there really was a true placebo arm in this study. And they injected into the inframedial, supramedial, and supralateral genicular nerves. The primary outcome was pain and disability on a visual analog scale, and they measured that at baseline, weeks 2, 4, 8, and 12. They also evaluated the WOMAC, or the Western Ontario McMaster's University Arthritis Index, which is a multidimensional score of arthritis symptoms, and then the IACOP, which is the Intermittent and Constant Osteoarthritis Pain Scale, as well as a patient satisfaction or global perceived effect scale.
Wow. I've actually never heard of a genicular nerve block for pain management. Is that something new? Can you tell us more about that?
It's interesting, right? It's certainly something I had never adopted in my practice. has been studied. There have been several prior studies, but none of those prior studies have included a proper placebo arm. And in some of those prior studies, the nerve block was done without imaging guidance or with fluoroscopic guidance. So this is really the first time that anyone has set up the study in this way. And our fearless team from Flinders decided a placebo-controlled study was really needed to determine whether this nerve block is effective for reducing pain in the short term for patients with long-standing knee OA. It's a really valid and important question because this disease is common. We know it's incredibly painful. And there are some patients who either can't have surgery, don't want surgery, aren't safe to proceed with surgery and want something just to give them some relief either in the long term or short term. So I guess this was a small study conducted at one organization, the Southern Adelaide Health Network. The patients were recruited from either rheumatology or orthopedic service. They had to be over 18. They had to have knee osteoarthritis as defined by the ACR criteria, with chronic knee pain at a level of 4 out of 10 or higher on most days for the preceding 3 months. They excluded patients with inflammatory joint disease, people who had an allergy to any of the injecting agents, patients who were pregnant or who had had an intra-articular steroid injection into the knee in the prior 3 months. They also tried to exclude patients who were unlikely to be compliant with follow-up or obviously those who could not give informed consent. Now, in the manuscript, they have pretty specific methods for how to administer the nerve block. I'm going to skip over that for now so we have a little bit of time to talk about their findings.
So yeah, tell us what they found, Vicki.
Okay, so they evaluated 95 patients. They randomized 64. Of those 64, they actually had 5 who were lost to follow-up fairly soon after the injection. So these were patients who received the nerve block injection and then were lost prior to that 2-week follow-up, which is weird, although it's also possible that the nerve block worked really well for those patients and they went back to life and work, and who knows? I would say in the analysis, they didn't impute missing data, so they just kind of missed those patients. Their primary outcome of interest was pain score, and what is clear is that clearly improved in the patients who were in the nerve block group compared to the placebo group. So the VAS pain score was significantly lower in the patients who received the nerve block at weeks 2, 4, and 8 compared to placebo. That difference became non-significant by 12 weeks. So this is a fairly short-lived impact, wearing off probably around about 12 weeks. They saw similar differences in the WOMAC scores, with those improvements actually remaining significant at 12 weeks. And then the other scores that they measured improved compared to placebo. So the ICOAP and the GPE scores improved compared to placebo at 2 and 4 weeks, but weren't significant at the 8 and 12-week follow-ups. Notably, they didn't report any complications from the procedures, although I would note that they state that they had the nerve block procedures performed by a radiologist or a rheumatologist with an experienced senior sonographer. So clearly, this is a procedure that is not going to be something you do necessarily alone in your clinic. It's probably an interventional radiology procedure. And I would also note that the interventionist was not blinded. So they knew that they were injecting the nerve block agent or placebo. I do think it's interesting because, this intervention seems to provide a reasonably durable improvement in pain. And I think it could have a role for some patients, just, those people who just want to be able to walk their child down the aisle at the wedding. We all have seen those patients, right?
Yeah, I think we all have those patients in clinics, and it's great to at least have some ability to provide them some short-term relief. But, I wonder what happens afterwards, right? 8 or 12 weeks later, they're still in pain. Is there any information about repeated injections?
As of yet, no. Unfortunately, I do think it would be nice to know if this is a therapy that can be used repeatedly. And I'm kind of interested to know whether with durable pain improvement, is there an impact on ability to exercise? And then down the line, does that have any impact on ongoing damage? And dare I say it, since we're talking about weddings, for better or for worse, I guess it could go either way, right? Patients with less pain might exercise more and thus have lower progression or slower progression, or the other way. We've actually seen with some of the other agents for OA that seem to have an impressive action on the pain pathways seem to result in more rapid progression of joint damage. And so either way, I'm glad this study was done. I give kudos to the investigators. I'm glad it was selected for presentation at ACR Convergence, and I'm looking forward to hearing more.
Like I said before, having more tools in our toolbox is great, and being able to offer somebody a local injection that may not have such systemic side effects and at least provide, a short-term pain relief seems really interesting. My biggest concerns, as you mentioned, is sort of what happens long term. The body has pain for a reason, right? To prevent injury in general. So if you block those pathways, are these people going to develop worsening osteoarthritis over time because they're not realizing that, the things they're doing may be causing harm? At the same time, I like what you said. Maybe these people are actually going to be able to exercise and work on their quadriceps strength and actually have a long-term relief of pain because of the exercise that this allows them to do.
I think it's a great question, right? It's like one of those metaphorical questions. If the tree falls down in the forest, does anyone hear it? If you can't feel the pain from your osteoarthritis, is it hurting you or hurting your
good
joint?
Point. I love it. The other thing that you mentioned is that, this was, experienced radiologists doing these nerve blocks. So I'm thinking about cost, thinking about who would administer these. But, I think it's a great study, and certainly I want to learn more about it.
This study, I feel like, needs a long-term extension too. And I kind of wish they'd done at least incorporated some level of baseline imaging so that when they get to the point where they're doing, long-term follow-up studies for these patients, that they could actually look at that question of, is there a long-term impact for this short-term pain relief? Now, I know that we're short of time today, and I probably need to wrap things up, but I did just want to let our listeners know that we're going to try and get each of these manuscripts discussed more fully in its own episode of ACR Journals on air in the coming months. So I will be inviting the authors to get to hear about the trials and tribulations behind the trials. I will put in a plug that I think it's actually fun to try and start crowdsourcing some questions. So if people listening to this podcast have questions they'd really like to pitch to these authors, please send them to me. And you can either direct message me on Twitter, or we also have a spot on the ACR Journals on our website where you can send in questions or suggestions. Those messages get received by our editor, Joe, who will kind of pass them on to me and will come up with which podcast they should go into. It's really been a pleasure, John, being on the show with you again for this hot off the press edition. I don't know who's hosting, so I'm going to say thank you for having me and then just let you do the closing.
Vicki, thank you so much again for joining us and doing this hot off the press edition. It's never been done before, and I couldn't have asked for a better guest to discuss these really three impactful articles that are being presented at Convergence. And I'm really excited to continue listening to your excellent podcast and hearing sort of the opinion of the study authors and getting the nitty-gritty details about these studies. Vicki, I'm sorry I won't get to see you at Convergence, but maybe I'll wave to you virtually from the cameras.
Oh, thanks, John.
Thanks again for joining us.
Have a great day.
Thanks, you too. Well, there you have it. 3 landmark studies that you can now discuss with your colleagues. Don't forget to check out Vicki's podcast, ACR Journals on Air, as she discusses each of these manuscripts with study authors over the coming weeks. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, Google Podcast, Spotify, and Stitcher Radio. Please keep reading, keep researching, and of course, stay healthy.